And last but certainly not least, we have Dr. Kelli Braun. And just know, I've ordered up good weather for the afternoon, but it's not supposed to quit raining until 2 o'clock, so we have plenty of time. Dr. Braun is professor of OBGYN and senior associate dean for admissions at MCG at Augusta University. After her completing her medical education and residency at MCG, she joined the faculty in 2008. She is recognized nationally for her work in low-cost simulation models for surgical training and has received multiple teaching awards. She balances her clinical teaching duties with her leadership roles in admissions and research, including serving as principal investigator for national trials on uterine fibroids. And she gave me a sneak peek, we're seeing it already, into this basket of tricks up here. So this is going to be very fun. Thank you. We're so excited. Join me in welcoming Dr. Braun. And this is
forward, back, pointer.
Pointer.
Okay, forward. Hopefully the only one I need. So thank you for the introduction. Thank you for GOGS for having me. This is super exciting. Unlike Dr. Runring, who cures cancer, I do not. And so I am not going to inundate you with level A evidence. I apologize. This is going to be more fun and really just born out of a need. If you read Malcolm Gladwell's book, The Outliers, it's phenomenal. He really talks about how success is somewhat dependent upon timing and opportunity. And I won't say that this is necessarily success, but for me it was really dependent upon kind of training. And so I trained from 2004 to 2008. It's when many of us were converting open procedures to laparoscopic procedures. So I was really learning alongside my attendings. And so my UroGyn said, you got 7 minutes to close the vaginal cuff, go. And so I really had hoped that there were opportunities to learn those skills, especially these advanced things or maybe low volume things that we weren't exposed to in an inanimate environment. So this was really born out of a passion to push it forward to the next generation. I am a graduate of the APCO Surgical Education Scholars Program. It was an inaugural program, I think in 2013, where it took educators and it taught them how to do simulation. Dr. Rungering and I were also former members of the ACOG Surgical Consortium, which was, again, a group of educators that were trying to provide national curriculum for our OBGYN training programs. So, I have no financial disclosures. I actually get very little time or FTE to do this work. So our objectives for today, we're going to talk about the history of simulation in medical education, where this really came from. We'll talk about simulation and OBGYN certification. I'll show you some pilot models that we have tested in our OBGYN training program. And these were not to really do substantial research on, but really to just fill a need for our residency training program. We'll talk about resources for simulation outside of OBGYN training, because I know many of you are not in the graduate medical education realm anymore. And then hopefully have fun. So I realize I am the last thing holding you up from the beach. So simulation, what is it? It's imitation of a simulation or process. And so it's a valuable tool that can increase technical skill, which I think many of us think about, but it's also much more than that. It's communication, it's teamwork, it's decision making. There's tons of simulators available now. It's really been this boom since about 2000. There can be anywhere from low cost, which you see on the screen. We have a vaginal hysterectomy insert that we had created, to high realism mannequins. This is a Lucina birthing simulation or simulator. We actually have one in our medical school. Suture blocks, standardized patients, high fidelity. So the Lap Mentor, you can learn how to do laparoscopic robotic procedures. And simulation, the really key to this is that it should include feedback and should be purpose-driven. So you have to decide going into that. Are you going to do it for an educational component, which is what we really strive to do, or isn't it for an assessment? So I'll give you a little brief history of simulation and where this came from. It really started with the aviation industry. So it was first used back in the 1920s with the link trainer. This was a small wooden airplane with a fuselage, and it had wings mounted to it on a universal joint. It had a cockpit with standard controls so that pilots could go and learn in a simulated environment. That then led to the Link Flying School. It further expanded in World War II due to a need. They had to train a large number of teams for complex missions, so it wasn't just a pilot anymore that was dropping bombs. You had to have a navigator, a pilot, a bomber. Then in 1979, the majority of pilot training was completed on simulators, and they then became the standard of care, or standard for consistency of training, and is now the standard for pilot training. Very interestingly is when I did the Surgical Education Scholars Program, one of my colleagues, Michael Breen, was a former military, and this is when the dual console came out. So his project, and it's actually been published, was about how do you do the transition, who's in control of the instruments now. So there was a handoff, just like a pilot, co-pilot. And so aviation has really translated into medical education. So it's not just skills, it's also communication. A lot of this, again, was born out of the military. So many of you, if you've read some of the Malcolm Gladwell, he talks about war games. So this is really high realism. And so it doesn't have to be fidelity where you're actually on a battlefield or having the tools. This is more about communication. So war chess was created by Weichmann in 1964 to train military personnel in communication and skills and the basics of military science. So you can see it's a general board game almost in front of you. They have two teams who are master in decision making and strategies and counter strategies, and they have an umpire there. One team makes the decision, send it to the umpire, and then the other then has to do strategy. Again, it's characterized by high realism, emphasis on experience and decision making rather than the competition, so who can outwit the other one. The umpire keeps the rules, keeps it flexible, and this is still used in the U.S. military. They do global war game series at the U.S. Naval Academy, and they've even created virtual environments for which to do it. So how does this translate into healthcare? And it's been used in healthcare for a variety of things. Again, technical skills, communication, critical decision making. Mrs. Chase, which is the first picture you see here, was introduced in 1911. It was a life-size doll built by Martha Jenkins to train nurses on how to dress, turn, and transfer patients. In 1940, they came up with a male version from the U.S. Army to teach medical corpsmen different techniques of hospital care. Many of us are familiar with Rescue Annie, so this was for CPR. This came out in 1960, and then the boom really started in the early 2000s. Sin Man, which is the last one you see here, was the most realistic mannequin. He had cardiac sounds, breath sounds, CPR. This really transformed how we do medical education. So here at MCG, we are foundation of simulation-based education. We really focus on experiential learning. It's been shown to improve the quality of care, reduce errors, and it allows the learner to practice skills in a low-stakes environment. So if they panic, you can say, time out. Let's talk about this, rather than when they're with an actual patient. In 2011, this is the most recent study I can show. Clearly, it's outdated, but at that point, they showed that 68% of undergraduate medical schools and 25% of teaching hospitals included simulation-based education. I guarantee you those numbers are much higher now. What you see on the screen is the core of our curriculum at MCG. There is experiential learning incorporated throughout all 4 years of their education, and I tell applicants on interview day, I wish I could have learned this way. It gives them an opportunity to start thinking like a physician from day one. So we put them in simulation where they have to start making the decisions. And I'll say, as an old school learner, I didn't get to start doing that until I was an intern. And that was pretty intimidating. So they have educational simulation, a center for ultrasound, telemedicine education, and procedural skills built in. This is the new foundation. And then resident education. It's been increasingly incorporated in graduate medical education. Surgical programs have had that as a requirement since at least 2010. And it's really an optimal method to teach the adult learner to gain technical skills and proficiency. Again, it's a low-stakes environment. We can pause, take a time out. So particularly for those things that feel more high risk or that they have low volume for, this is a great opportunity. And it's been shown to standardize training of surgical skills and improve learner skill performance in those complex things. So this is all education, but what about assessment? So many of us know it's now required for OBGYN board certification. So this is where it started. If you're not familiar, this is the fundamentals of laparoscopic surgery. This was developed in 2004 by SAGES. It's a two-part cognitive and skills proficiency-based curriculum. And it was meant to teach a minimum standard for laparoscopic surgery. So there's 13 online modules, which is education-based, and then skill-based. They have to do these 5 tasks you see here on the screen. So there's peg transfer. They have 6 pegs. They have to transfer them from one side of the board to the other side and back within a specific time. They can't drop any. Pattern cut, they have to excise a circle from a double-layered laparotomy sponge, essentially. Ligating root, place a loop around a specific area on a foam finger, a single extracorporeal suture, and a single intracorporeal suture. So let me go back real quickly. So these metrics have been extensively tested and validated for reliability, feasibility of administration, and appropriateness of passing scores. And again, they have to practice to proficiency. So what does that mean? So this was introduced in 2006. They took 2 expert physicians that practiced all 5 of these 5 times a piece. They took the average and said, if you can practice this, you're going to pass the exam. So now all of our learners do that. So performance with these technical skills actually correlates well with intraoperative performance. In 2009, the American Board of Surgery actually required FLS certification for licensure of its applicants. In 2020, ABOG actually introduced passage of the FLS for certification for our graduating residents. As of 2023, I'll show you EMIGS on the next screen. Residents can alternatively take that. We were early adopters of FLS, so you can see kind of the timeline of where this came along, and it's right at the point that we were converting open to laparoscopy, and then how do you train in a minimally invasive environment. So our program actually had some buy-in to this in 2013. We were one of the first OBGYN programs that actually tested this, and it's now been incorporated, as you can see, in certification. Oh, one last thing, sorry about going back and forth. Some people will question the utility of FLS, again, because there are certain things you're not going to do a peg transfer within a patient, right? But it does teach you hand-eye coordination and timing. So in 2023, this is a pretty updated article. Higgins demonstrated that surgical residents actually required more supervision in laparoscopic procedures before the exam than after the exam. So there's actually some utility, and they say that you should actually do and complete the certification early on in your training. So for us at MCG, they're actually required to do that by the end of their 2nd year. So this is now the alternative. This is EMIGS. This was put out by AAGL. There are 12 content modules. It includes hysteroscopy and 5 technical skills. They've essentially removed the ligating loop and added a running suture. It's a 22 centimeter. It's got a pre-tied knot, and they do not have to tie the knot at the end if they do the running suture. But the didactic content is supposed to be more pertinent to OBGYN, whereas they say for the FLS, some is a little bit more pertinent for general surgeons. Okay. So now we're going to transition to all of the crazy things that live inside my head. I'll show you how we made these models. I do have some Vanna Whites. Dr. Woodham, Dr. Rungrang, and Dr. Lateef are going to come pass out some of these models. I'll tell you what they are, but they felt very strongly that you should be able to touch and feel and move around with them. Okay, so where did this come from? Again, we started with almost 0 budget. We just had some faculty members that were very excited about training our next generation and giving them opportunities. But we had very little budget, and we had 20 residents to train. And so we said, how are we going to do this? And really essential for me is that it had to be low cost. A lot of this I was paying out of my pocket, or sometimes we had some funds for that. It needed to be realistic, anatomically correct, had to be reusable because the cost of having to replace everything was very difficult, and it needed to replicate the steps of a specified procedure. So we wanted something that was very consistent and structured for our residents. So this is the simulation format that we've been using for almost the last 10 years. It's a 2-hour session. We do it once a month. Our residents get assigned pre-reading on the topic that we're going to cover, whether it's a skill or a procedure for that day. They get a 10-question multiple choice test, followed by 30 to 40 minutes of didactics from a faculty member, and then 60 to 90 minutes of hands-on simulation with the model or communication skill that we're going to do. And that's actually based on literature. It's shown that if you practice for more than 90 minutes, you actually get learner fatigue and they start doing worse. You need to take a break. And then we follow it back up with a post-test. Our curriculum is on a 2-year rotating schedule, so we include all of the essential milestone procedures. So if the resident didn't get it the first 2 years through, they're going to get it before they graduate. And we focus on both knowledge and skill acquisition. All of our residents participate, so all 20 that are available will show up. It's not level specific. And as I mentioned, we were an early adopter of FLS, and so that is not included in this curriculum. They'll complete it by the end of PGY2, and then our robotics curriculum, who's run by Dr. Sims Johnson, who is here, that's also separate. So with doing these, if you look at the literature, people will always say, well, yes, their knowledge and skill acquisition immediately following the simulation is going to improve because you just gave it to them. But what about long-term retention? So a couple years ago, maybe 3-4 years ago now, we said, okay, well, how can we reinforce those skills that we've taught them throughout the year? And so we came up with this amazing race-style simulation Olympics. So it's at the end of their academic year. And we start with the Jeopardy. We divide them into teams of 2 or 3 with PGY level equivalents, so say a 4 and a 1, a 2 and a 3, so that you don't stack the deck. They'll do knowledge, and it's only on the content that we've given them throughout the last year. This year, Taylor Swift was really big, so everything was Taylor Swift themed. You can see there's ready for it, and then all of the categories related. So for instance, bad blood, postpartum hemorrhage, it was all pretty fabulous. And then they have 5 tasks that they're gonna have to complete. If you've never seen The Amazing Race, they have a pit stop. We have a faculty member at each of those tasks. They don't know what they're gonna be. So it could be anything that we've done throughout the last year. They're given a clinical scenario, and they have to pick one of their residents to perform it. It's not for a grade, but it is for points, and whoever gets the most points gets bragging rights. You can see them here. They get a GOAT trophy and some gift cards, and it is a fun way to reinforce all of the things that they've done. So again, we do this with minimal budget. They've seen the importance, so we now have 3 faculty members. Dr. Rungrang is our GYN simulation coordinator, and we each get a little bit of FTE to do it. And we do keep an IRB just because if we're introducing new models, again, it's not for research purposes, but we would like to be able to share that data with other programs and make it available. So now we're gonna play a little game. So you can see what's inside my head, and you may never see things the same again. But again, we had to do things with little budget, so I have to just look at inanimate objects and think about how they can now become anatomy. So on the screen, looks like red balloons, right? So what I see, are round ligaments and fallopian tubes. This is from our tubal ligation model that we've done. And then this is a more advanced vaginal hysterectomy insert. Might see a maraca. To me, that is a uterus with the manipulator, so I use it for laparoscopic things. On the left-hand side is a new bilateral dermoid model because, again, it saves cost if I do it bilaterally. And this is a laparoscopic ectopic model we've presented before. And then this one is my favorite. Speaking of embarrassing your children, this is my son, who's now 16 and doesn't know that he's in this actual thing. But to everybody, this looks like a pink cowboy hat, right? To me, that's a vulva. I just happened to look down and cut it out. There were vaginal hysterectomy trainers that were out there previously. But the challenge is there was this beautiful flower pot model, but there wasn't any depth to operate through. There was no cap. And so I just happened to be walking through Michael's one day, looked down, it looked like a vulva, I cut it out. And it's now been used by a lot of training programs. So this gives you a little peek to what's inside this head. All right, so now what's being passed around are some of the other models, and I feel like the ones that we use a lot of the time. Surgical management of postpartum hemorrhage. Our residents will do lots of O'Learys, but sometimes they may not get a lot of exposure to the compression sutures that you have to use. So we created this uterine compression model. It's being passed around. They're about $7 a piece. They're completely reusable. Once you make one, you never have to do anything else with it again. The one that's being passed around is probably 6-7 years old. There was one that existed in the literature, but it was with felt. It had a little bit of foam batting, and it more rolled than compressed. And anyone who's done a V-Lynch knows you have to really squeeze that sucker. So we created this one as an alternative. It's reusable. We use it in more complex models. So for instance, CHIS models, that's the base for that. We also use it in a postpartum hemorrhage model where it's mounted and they can place a JADA. And when we did our initial testing, you can see there are resident with her V-Lynch here. You actually just tape it down to the table. You can mount it in a pelvis any way you want to use it, and it does improve their confidence with doing it. And I think this is the one that I get the most text about that says, I'm out in practice, I did a V-Lynch today, and I knew how to do it because we did it in simulation. Next up, tubal ligation. This again just came out of a need. There were less postpartum tubals being done immediately in the hospital for long-term contraception, or insurance couldn't cover it, anesthesia wasn't available to do it, you name it. Our procedure volume had just gone down, and I noticed that our residents were struggling with this a little bit more. So we created a tubal ligation model. This was actually just published in the Gray Journal in the Surgeon's Corner. So I just took a latching storage container, so it would have a contained abdomen, cut a hole in it, use plastic lays for bowel. You can see all the other things here, multiple layers of the anterior abdominal wall. And this is what it looks like completed. You can actually manipulate the box, so if you need a little bit of T-bird or motion to one side or the other, your assistant can do it. It can be used for salpingectomy, but our residents were so comfortable with that, they didn't necessarily know how to do alternative forms of tubals like Pomeroy. And what happens if you can't actually get the rest of that tube up? So we wanted to recreate that. The really nice thing about this is it can be modified. So if you want to simulate a thicker anterior abdominal wall, you can take more of the foam and layer it up. If you want to make it more challenging, you could add more plastic lays and actually have them pack that away as bowel. The other nice thing is we talk about reusability. That whole anterior abdominal wall can be used twice. So you just mark a little belly button, they make one incision on one side, and after you've completed it, you take it off the tubes, put new ones on, that cost about 50 cents, and then you can use the other side. So 2 learners can actually practice before you have much cost involved. So our residents agreed strongly that it replicated the steps of the procedure, replicated important anatomy, and then additional practice with the model could improve their surgical technique. Okay, so you've seen kind of my Michael's Party City versions of models, but when we talk about, and Malcolm Gladwell with the outliers, access and timing is really important. So we have the only medical illustration department in the state of Georgia, and so just from a timing and opportunity standpoint, we built this beautiful collaboration with them. And I'll go ahead and give a shout out to Dr. Amanda Baer, who is now the chair of that department, and Dr. Sandra Reed's daughter. So shout out to her. So this was the process that we started with medical illustration. We thought maybe we could make them a little more realistic. We still want them to be cost contained. And so when you consult with a medical illustrator, it's this beautiful process because they know all of the different materials and you know the anatomy and the steps of the procedure, and you work together to build something kind of new and unique. So you start with your needs assessment. We start with sketches, prototyping, testing, and then the final product. So I'm going to show you a few of those. So you saw my initial cowboy hat vulva. These are ones that were recreated. Actually, Dr. Latif and one of her medical students, when Dr. Latif was our clerkship director, wanted our boot camp students to be able to do cervical exams. So they created these models so that you could practice cervical exams. Next is the bladder model that's going around, and this was really our first foray. So we had a low-cost model that I had presented a few years ago. These were about $1.50 a piece. It was a whoopee cushion, which was your inner mucosa. It was shelf liner because it's a little more rugged. That was your muscularis. And then press and seal, which was your serosa. You could cut the top off of it, put a Foley catheter inside, slap it in a laparoscopic trainer, and then residents could practice the repair. So it did its job. It was effective, it was low cost, and it replicated the steps of the procedure, but we really wanted something high realism. And there were some limitations to this, so they couldn't check the integrity of the cystotomy repair. They couldn't check the trigone. They couldn't do cystoscopy. So we said, this is the challenge, and what was created you see here. So it has rugae. We did 2 different colors for the mucosa and the muscularis, so if we have to do a 2-layer closure, residents can see exactly where that was. It has a trigone and functional ureters. So once they put it back together, we could actually put a cystoscope in, or one of the portable hysteroscopes that you see out there from our vendors, and then we could shoot fluid through and they could actually see ureteral efflux. So the process of that was pretty complicated. It went through multiple different molds, and Amanda would tell you that doing a negative space, which means something hollow, is actually quite difficult to create. So it was a 3D printed mold, silicone pigment. One of our former students, Megan Chesney, this was her summer research project. So again, it was great collaboration. So we created 8 models for about $206, and they are completely reusable too. So you can actually take silicone and spot seal over the top of it after it's been used, and again, can continue to reuse it. Again, our residents agreed it was useful for teaching, realistic, and improved their confidence in cystotomy repair. And it had the bonus of being able to do cystoscopy. So this was it in training. I'm not going to go through the whole video, but they could actually backfill the bladder, make sure that it's watertight. And then we come to cerclage. So we actually pulled Dr. Woodham in on this project. We had a previous low-cost model. So this was a foam balloon, or one of those foam things that you use in the pool. We cut it down to the size of a uterus. We took one of those vaginal cuffs that were provided with Ethicon previously, put it on the top, put it in our cowboy hat trainer, and then that was a great low-cost model that they could practice exam-indicated cerclage. So we also wanted something that was a little bit more high realism, again, operating through that space. So she actually updated the vulva. It was a whole, you can see it, it's going around. It's very stretchy because you have to be able to use retractors, and there's some give and take on the materials. You don't want them to be so realistic that they give way, but you need it stretchy enough that you can actually operate through. So this is a picture of both the history and exam indicated cerclage. You can see it there after repair. So it went through the same kind of steps of process. We constructed 8 models for $57 a piece. It was a 3D printed mold, silicone, pigment, foam, Velcro, and it sits on a PVC pipe and wood base. These are completely reusable. You can transport them places. Residents agreed that it was realistic, replicated the steps of the procedure, and agreed continued practice would improve procedural proficiency. And this is it in resident training. You can see one of the exam-indicated cerclages being performed here. And it is a dark hole, so we did buy headlamps from Amazon so that they could use that as a light. And then there's just been really great benefits for us with our medical illustration team. That's Amanda here in the middle. To the right is Megan Chesney, who was the student who did the the bladder model. Dr. Latif is holding a circumcision model that we had, and then Dr. Runring, as you see here. But really what we learned that the resulting product is better than if we had approached it individually. It takes blending of art and medical procedure skills. It's a true collaboration. And then what you really learn is it's negotiation of resources. You as a provider want all the certain steps, but then sometimes you realize maybe you don't need ovaries for that uterine compression model because how often are those actually in the way? And then if you wanted less density on the bladder, when you actually suture through it, it's gonna leave small holes and then you can't test the integrity. So there's definitely some give and take between realism, cost containment. There's some limitations of the materials themselves. And it's blended scholarship for us. If you consulted with a medical illustrator yourself, there's going to be lots of budget involved in that because their time is very expensive. But because we're in a training institution, we use lots of their graduate students, our medical student, and it's just been a great opportunity for us. So what does this mean for you outside of a graduate medical education? There are tons of simulation resources for practicing providers. One of my favorites, and we actually use these in residence training, is AIM. So it's saferbirth.org. It's the Alliance for Innovation in Maternal Health. It's a national cross-sector designed to support best practices that make birth safer to improve maternal health outcomes and save lives. And so the AIM national team, which is with ACOG, provides technical assistance to all of those who want to do simulation. They provide simulation and drills for patient safety, obstetrics in situ training programs, practicing for patient simulations. And this is an example of the case scenarios that they have. All you have to do is click on this website and every single one of those scenarios are there for you if you're not using them already, especially in residency training. All you have to do is download it. It's fantastic. And we've actually used these as a basis to build other things like trauma, maternal care. So it teaches you as a facilitator what to do. It teaches you what each learner role is going to do. It comes back with a feedback checklist so that at the end you can all have a nice feedback session. Everything that you need is there. And then for inside of residency training is the surgical curriculum and the CREOG Surgical Skills Task Force. You can see, I don't know how well it projects on this screen, but they have basic hysteroscopy, cerclage, cystoscopy, IUD insertion. So if you're somebody who just wants to re-practice skills, or if you're in residency training, all you have to do is click and everything is there for you. And then finally, for our practicing providers, ACOG offers the emergency and clinical obstetrics. It's a hands-on practicum, half day. It's a $125 flat rate for anybody who wants to participate. It's a 3-hour online course and then a 3-hour simulated training. And it gives you breech vaginal delivery, shoulder dystocia, postpartum hemorrhage, cord prolapse, teamwork, and communication. And I believe you do get some credit for this as far as simulation. But again, that's all available. So a thank you to our simulation team, our medical illustrators, our residents and faculty who have great buy-in and are just so supportive of this programming that we do. My amazing family here. The one I didn't mention is Dr. Carolyn Zoller in the middle. She's our OB simulation chair. And y'all probably recognize that guy in the middle. Okay, references here. And with that, I'll take any questions. Hopefully none.
I think in the future we have to have the actual simulation
Yeah.
set up. We'll have skills
We'll be
tests,
happy to do that.
contests, prizes.
Oh, Dr. DeVoe.
Well, Kelly, I've known you more than just for a little minute or so.
Yes.
And first of all, I want to compliment you on a terrific presentation of
Thank you.
the work that I've watched you do over the years, and going from your student level yourself up through residency and now a senior faculty member. And I want to give you a sneak preview of coming attractions, because the actual surgical literature, both general and specialty surgical literature, has gone to one step ahead. And that's called using AI observation of surgeons actually at work to, number one, determine how good they are in terms of their skills, and if not, what needs to be corrected. And these are things that are going to be implemented into surgical training in the future without doubt. And so I would suggest that you might want to look at putting that into your program so that you have objective, reproducible ways of assessing skill that have nothing to do with how one feels about another person, but how a routine that's completely impersonal but objective says this is how you're doing and this is what you need to do better.
Okay. Thank you. Okay. Well, objective, you know, reach, we're getting this out early. Yes.
I wish I had fixed the rain, but oh, well. Can't do everything. So thank you, everyone. Thanks for a great session. A couple little reminders on the way out of here.